Hi, I and Miss Huong very happy to be the speaker today. Yes, now we will talk about the nasopharyngeal fistula closure utilizing the ADM Acellular Dermal Matrix. The first of this our introduction is Miss Huong. She will introduce about the uh, surgery about fistula, and then I will present about the using ADM to close the fistula. Yeah, Miss Hương, you okay?
Yes. Hello, Professor, and hello, everybody. My name is Hoang Thi Huong, Doctor of Dental Surgery of Hanoi National Hospital, Odonto Stomatology. I'm very honored to be speaker of 2022 workshop on novel biomaterial in oral surgery. Today, I will report the subject nasal alveolar fistula closure utilizing Acellular Dermal Matrix. Now, firstly, I want to talk about the review of cleft palate and fistula. Cleft palate is the birth defect in the maxillofacial region with a high incidence in Vietnam. Worldwide, the prevalence of the disease accounts for about 1,750 to 1,000 newborns in Vietnam. This rate is about 0.1 to 0.2%. The goal of palatal surgery is to close the communication between the oral cavity and the nasal cavity, and to build a functional short palate that allows for good speech. Next, please. There are many methods to palatal blast to close the palate. The von Lazenbeck in 1861 we use two back please. Von Lazenbeck we make two incisions at the lateral side, and we make two flaps with the reservation of artery. Another method is two flap. We have two flap method. Two flap of view when Green Kidner with pushback technique in 1937 and two flap of Badak in 1967. In my hospital, I usually use this technique for to perform palatoplasty every day. And another method, we often use double Z or follow techniques in 1978. In this technique, we make double Z flap, and this make the sweep able for short flap and make the short palate become longer. So why we have oral nasal and nasal alveolar fistula? Oral nasal fistula (ONF) is a commonest complication of cleft lip and palate surgery, from 4 to 35%. Rate of ONF in bilateral is more in unilateral. Nasal alveolar fistula is the most popular type of ONF. Symptomatic NAF is associated with nasal regulation, hyponasality of speech, and the eruption of tooth. So what's the reason of fistula? There are many reasons of fistula. I do every day. I perform every day palatoplasty. So I think the reason includes the closure under tension, vascular accident. Vascular accident during palatoplasty will affect blood supply, and can cause flap loss, and so they may lead to develop the fistula. The experience and techniques of surgeon is very important, and post-operative infection is the reason of fistula. About classification, we have many types of fistula. We based on size or location. With the size, we have three types. Small, if the fistula is less than 2 millimeter. The medium, if the fistula is from 3 to 5 millimeter, and the large, if the fistula is more than 5 millimeter. And the location of fistula can be is anterior fistula, mid-palatal fistula, or fistula at the junction of hard and short palate, and fistula in short palate. We have the fistula classification system. There are 7 types of fistula based on the position. Purpose of fistula closure surgery. The goal of fistula closure surgery is to improve pronation, separate the nasal and oral cavities, create the basis for bone grafting in the secondary surgery, for tooth eruption, construction of continuous arch form and alveolar ridge, increase bone volume for dental implant. When we choose the flap, the surgeon designs the flap based on the palate vascularization. We can insist into incision. You can see the blood supply of non-cleft palate vascularization, and in the unilateral cleft palate vascularization. Recent method of ONF or NAF. We have 2 mainly methods of ONF and NAF. 1, surgery treatment, and 2 is non-surgical treatment. With the surgery treatment is the first choice. At least we should do at least 6 months after the previous surgery. And with non-surgical treatment, we use when the surgery treatment is unsuccessful. There are many methods to closure the fistula. Includes local flap, redo palate, buccal mucosal flap, and facial artery myomucosal flap. Mucosal or myomucosal flap from the undersurface of the lip, tongue flap. Other flap like free tissue transfer, turbinate flap, temporal parietogalia flap. Choose the technique depend on the size and position of the fistula and the amount of scar tissue present around the fistula. This is local flap. Local flap with indication is usually used for a small fistula. We can perform with one with single layer or 2 layers closure. But if you use a single layer, the recurrence rate is higher. With redo palate mean parodoplasty. We usually use two flap techniques. Is indication the indication is for mid palatal oral nasal fistula and have adequate palatal tissue, variopharyngeal incubating. Two flap technique is very used for redo palate, long and narrow fistula with the axis along of the palate, and with mucosal myomucosal mucosal flap from the undersurface of the lip. This technique is very helpful for anterior fistulas. This is particularly helpful for anterior fistula where there is deficiency in oral mucoperiosteal layer. The flap can be transformed into the palate through the alveolar cleft and can reach 3 to 4 centimeters into the palate. Similar flap can be taken by laterally in case of bilateral cleft lip, and a palate to close anterior fistula on either side of the free maxilla. With tongue flap is we usually use for the bigger oral nasal fistula. We can do with the local flap. With this technique, we have to state procedure. It can be anterior or posterior side of fistula, and it's very helpful for the large fistula. With the partial mucosal flap and buccinator myomucosal flap, the fistula is situated near the hard palate and soft palate junction. The original cleft is wide. Part of the buccinator muscle can be incorporated in the flap, so we can call this technique is buccinator myomucosal flap. And the last technique is facial arterial myomucosal flap. In this technique, we use the
yes. In this technique, we create the flap anterior to sternum duct, and we this flap have the facial artery, and move to the anterior of the teeth, anterior of the jaw, and even change the maxillary to touch the other side in the middle of the palate.
There are many illustrations about FAMM. So whatever your method, you should to remember surgical principle. We have to closure with 2 layers closure. With 2 layer closure, the fistula should be closed into 2 layers. Both of the layers should have well cularized tissue, and the suturing should be free of tension with 3 layers closure. The intermediate layer can be cartilage, bone, and Acellular Dermal Matrix. So now I will introduce Dr. Pham Nhật Quang to continue talking about this subject.
Yes. Now I will talk about the ADM. Follow FDA's ADM is a type of surgical mesh. Is developed from the human skin like alloderm or animal skin like ABCcolla Collagen Matrix of ACRO company. In which the cells are removed and the support structure is left in place. Some ADMs have been cleared by the FDA for use in certain types of surgeries, and the core nature of ADM is collagen scaffold. Now I want to talk about the systemic review of ADM using the current review and survey arms to assess the effectiveness of the ADM in the repair of cleft palate and oronasal fistula, and to evaluate the current trend of ADM used in palate surgeries. 12 study met inclusion criteria for review. Study was very of low quality as indicated by methodological index for non-randomized studies score ranging from 7 to 14. The pool estimate for fistula formation after primary palatoplasty follow ADM use was about 7%, and the pool estimate for recurrent fistula after attempt repair using ADM was 11%. 36 cleft surgeons respond to the online survey studies, and 40% use ADM in primary cleft palate repair, while 67 use ADM for repair of oronasal fistula. So the conclusion is use of ADM products is more common in palate surgery, but this is not too much the high quality data. So the further randomized control trial are required to help develop structural guidelines and improve care. This followed the Andrew Simpson in 1990. I know, 2019, 2019. I'm sorry. This the advance of ADM in on ONF and ANF fistula closure. This create a collagen scaffold and support to close the fistula. Then this reduce the use of regional flap like buccal flap, tongue flap, and FAMM flap, and this reduce the invasive the destroy of the structure around the fistula, like the facial artery, the turbinate, or the vestibular. Of course, this reduces the threat of the flap, and the surgical process is quite simple and safe because it's not because the the implantation of ADM is quite normal. It minimizes the bleeding, the necrosis, and the scarring, and of course surgery time. The surgery time for the regional flap is too much if compared with the using of ADM, and it increases the thickness of the soft tissue around the fistula. This this the most important thing in our opinion. because when it comes time for bone grafting later, the gingival tissue in this tissue we have to divide into two parts, the plateau side and the buccal side. So if the tissue is too thin, it will increase the risk of flap necrosis and bone exposure after transplantation. Currently, our department had conducted for about nearly 20 patients using ADM, and all of them currently have no recurrent fistula. All are the nasal alveolar fistula with the arm of increasing soft tissue size. At this time, we have not applied it to the primary cleft palate because in our department, the occurrence of fistula complication in other locations after surgery is almost non-existent. So only cleft alveolar or the boundary between the primary and secondary plates is usually seen. This advance of the ABCcolla Collagen Matrix. The advance of ABC Collagen Matrix is very similar with the advance of ADM which we need, but this have the big advance with the almost patient in Vietnam because it's cheap. Cheap is very important for approve it with many patients because almost patient is not rich, and when you do it, the patient will have to pay a fee for the material. But the ATM of ACRO is not expensive too much. Yes, and the supercritical carbon dioxide extraction technology is, I think is quite good. This is the material we use in this material we use in our department. This the matrix with the size 2 and 3 centimeters. In the first patient, now we introduce some patient. This first patient is the patient of Dr. Huong. He's a boy with 15 years old, and he have lip cleft and plate cleft, and he have suffered two surgery in the past. This is the initial picture. You can see the hole inside the alveolar, in the left alveolar, and this is the result after 1 month post-op. This slide is the incision. The incision flap is based on this, and we put the ADM to the cleft to rise the volume and close the suture. The next patient is my patient is she's 21 years old, and this the initial picture, and we design the flap. When we after we do the incision, we will release the patient, and we put the ADM between the bone and the gingival flap, and then we closure. This 4-month post-op. You can see the keratinized gingival is thick enough for bone graft in the nursery after 6 months later. And this is the X-ray, the Kunbim CT. The defect, the bone defect is still exists because we only do the soft tissue closure, but the thickness of the thickness is of the soft tissue is increased. It's enough and very safe for the bone graft. The third patient is still my patient. She's a female and 29 years old. This is the several case. She have completely bilateral cleft lip and blade, so she have alveolar cleft also. She suffered from some lip and blade repair surgery in the past, and her father bring her to dentist and create a bridge for her 12 years ago. You can see the bridge is quite terrible. At my first appointment, she had the bad breath and the inflammation, and of course, she had to remove this bridge. Many teeth was destroyed by tooth decay and terrible periodontal health and malfunction, of course. So at this time, we have to extract some several decayed teeth and give her the medicine antibiotic. And 2 weeks later, we will do the surgeon, the fistula closure surgeon. Here's the flap design. In this time, I extract the malfunction teeth, the unerupted teeth, and we use IDM to closure. This the result. 1 month post-op and 3 month post-op. You can see she have the high quality soft tissues because it is keratinized gingival. Very thick. This is the Kunbim CT of this patient. Nearly 12 millimeters of gingival tissue thickness. This is the last patient in the case series today. This is the male and 18 years old. This patient is very special because we use the double layer of ADM and bone graft immediately for the bilateral alveolar cleft. The patient it was done by Professor Tuan, the head of my department, and Dr. Huong. First, we expose the effect, and we create the layer in the ADM to the palatal layer. Then we do the bone graft. This bone was collected from the iliac crest bone. And then we do the PRF and do the second layer with ADM. Then we close the wound. This case is this case was done in the last week, so we don't have the image in the post-op. So in future, we will share the result. Thank you.
Thank you, Dr. Hoang and Dr. Hu, for your nice presentation. And I saw that there are several